remarkable advancements, fueled by innovative technologies, research breakthroughs, and the global push for healthcare resilience in the wake of the COVID-19 pandemic. One of the most notable advances is the refinement of mRNA vaccine technology, originally used to combat COVID-19. Researchers have leveraged mRNA platforms for other infectious diseases and cancer treatments. Prostate cancer treatment has seen promising developments with PSMA-targeted therapies. Another breakthrough is in the field of cholesterol management. New LDL-lowering therapies, such as inclisiran, offer long-term solutions by inhibiting the production of specific proteins involved in cholesterol metabolism. Furthermore, advances in regenerative medicine have demonstrated how lab-grown human liver cells can repair damaged organs. This technique opens up possibilities for treating chronic liver conditions without needing full organ transplants. Artificial intelligence is also reshaping healthcare by improving diagnostic accuracy and personalizing treatment plans. In infectious disease treatment, antiviral research has accelerated. Drugs such as Paxlovid have significantly reduced hospitalization rates among high-risk patients. Finally, the growing adoption of telemedicine has ensured that healthcare services remain accessible, even during disruptions. Advances in remote monitoring devices, combined with AI-powered analytics, have enabled doctors to manage chronic diseases effectively from a distance. In conclusion, the past 2 years have witnessed significant medical advancements across multiple domains, from cancer therapies to vaccine technologies and AI-based diagnostics. These innovations are not only enhancing treatment outcomes, but also reshaping the future of healthcare to be more patient-centric and accessible.
A very warm morning to everybody present here. I would like to congratulate LGS and Team for successfully running through 4 years. When we say 200 episodes, it's actually 4 years, and it requires a lot of tenacity and planning with dedication to do this. When Vidya madam called me to be part of this program and I heard the word moderator, immediately said yes, because it's very difficult to be on the panel. So I was reminded of the Thiruvilayadal movie. கேள்விகளை நீ கேட்கிறாயா நான் கேட்கணுமா கேள்வி மட்டும் நான் கேட்கிறேன். And then Pata sir reviewed me through a couple of web meetings, making sure I'm pretty decent in my English, etc., whether I'll be able to host 30 minutes of this elite panel. And then he said that my 30 minutes should be the best, but never did I imagine that he'll take over the first 30 minutes. So I'm very happy to welcome the panel on stage. And when I was presented this topic of contemporary medicine, I initially set my thoughts on what contemporary meant. So contemporary could be a time period in what we are set out to do. It could be just this single moment passing through our fingers, right, as we are enjoying it. Whereas it could also be the most powerful moment where we are planning for a better future. The contemporary period runs through decades in long missions. Human healthcare has been one of the longest missions and will forever continue to be as long as humans persist on this planet. So we have a lapse of time here in terms of senior professors who are still so active and able to be present here on a Sunday morning, right through all the way up to us, Sai sir, Sabha and myself. So without wasting further time, I would go through the contemporary medicine in the views of the elite people on stage. Straight away, Dr. Sabha, telemedicine has apparently taken over, and the success of marvelous medicine itself has been through the COVID period and through web meetings and such an elite gathering, all of us pulled together. How do you see telemedicine working out in the ICU? How do you think remote access is going to influence ICU care in the next decade?
Morning. Okay, yeah, it's working. So yeah, thanks for this opportunity, and congrats, Madam Vidya Ma'am and Patasa. So coming to your question, as we all know, telemedicine is becoming more and more popular, and the applications of telemedicine is very wide. We all know that right from primary health onwards to inpatient services, both in the wards as well as in intensive care. It's been used for quite a while now. In the UK, we used to monitor patients' ECGs in the wards. We used to have like a common display wherein there'll be a person who's placed 24/7. I'm talking about 20 years back. And I used to wonder, I mean, I was an SHO then, and I used to wonder that there'll be like 20 patients in the wards whose ECGs particularly would be monitored. And these are patients who would otherwise have to be in the intensive care unit or a HDU at least to be monitored. So we have come a long way since those times, and especially the COVID has changed things a lot, particularly in intensive care unit. There was a time where a lot of doctors were worried going inside the intensive care unit to start with, and when telemedicine was introduced, especially in Chennai, I'm talking about, there were a lot of people who were comfortable treating patients through monitoring from outside. People who were much younger were actually going in to provide the bedside care, and senior doctors who were considered as high-risk people were comfortably able to provide services. That made a lot of difference. That made a lot of difference because it requires experience makes a lot of difference in intensive care, and loss of senior people would have actually changed the outcome in very sick patients in intensive care. So that is when people, especially in our country, started recognizing the importance of telemedicine. That is one thing in the intensive care especially. And now there are lots of applications, different applications from reputed companies which have come in, wherein monitoring patients in intensive care has become quite easy. And you could probably safely say that other than the personal touch that you offer to the patient as well as the family, everything else can be done through telemedicine. And the resources required, yes, would be specifically designed. Yes, of course, you need the infrastructure. You need like a few different monitors to look at the patient's bedside monitor. You need to look at the ventilator. You need to look at the infusion pumps. So you need monitors dedicated to that. You need to look at the patient's radiology. You need a PAC system. You need to look at the investigation reports, and you need access to look at the patient themselves. And you also need a trained doctor by the bedside who could actually carry out the examination which you want them to do. And you also want them to perform procedures. So the doctor on the floor should be trained enough to understand what your expectations are. So when it comes to resources, yes, of course, you need preset defined resources, but when that is in place, you can almost provide 90-95% of what anybody can provide these days. Yeah.
That was actually a trip down my memory lane too, because during the COVID times, we had a lot of the post-discharge follow-ups completely telemedicine wise. Patients couldn't travel down every time. There were travel regulations, limitations in the number of people per vehicle to travel. So like I said, I think we have tasted the success of telemedicine right through the COVID pandemic, with stethoscope going out of use for quite a while. And it proved how the quality healthcare could also reach far and wide. Where people couldn't have access to coming to Chennai also, we have managed to support them on phone. Relatives of our patients, we supported on phone. So I think definitely telemedicine is going to come up big time in the coming decade. With sophistication, technology, connectivity improving, we should look forward for an exciting future there. Yes, sir, please, sir.
Yeah, I think you talked about it. I'm Dr. Ramchandran. COVID time, we had diabetes patients who are coming to us from all over India, from Calcutta, especially Northeast, Raipur, Coimbatore, anywhere. So we developed this diabetes care app, which is now even functioning. And we could see patients sitting at my home and connect them with the laboratories. Every day I could see 15 patients from different parts of India. Now, after the COVID, of course, I started going to the hospital, but we are still working on the app, because then I decided that I will continue the app work, and 3 days a week, in fact 6 days a week the app is still working. I see 3 days every day, pay all the patients only on the app. Now it's a very, very highly sophisticated app that we have developed. It's called Home. Diabetes care comes home. As you are aware, diabetes is a chronic care model, and most of the time you don't have to examine the patient. Most of the time they want advice regarding diet, regarding their weight, lifestyle modification, management of insulin dose or medicines. And that can be done very easily on the app. In fact, a chronic care model like diabetes, especially most of the asymptomatic diabetic patients, what you need is only just an advice regarding their dose of drugs and why the sugar went up and etc. So it's all in discussion. So when I do this, it's I can connect with the patient in Calcutta, and I connect with a physician assistant in my hospital, and I connect a patient's daughter who is an IT professional either working in San Francisco or in Bangalore in the same app, and I'll be sitting at home. And my physician assistant had already taken the whole history, so saves a lot of time for me. She tells me everything about the patient. When was the last time I saw the patient? What is the weight? What is the BP? And then she tells what are the blood tests done yesterday. Now we also arrange the blood test to be done in any part of India because we have 300 laboratories we have outsourced. So the patients get a complete care. Now if they are in Chennai, it becomes almost a virtual visit because we can do ECG, a fundoscopy, a picture, and also leg examination in the house, especially for patients who cannot come out. Now what has happened is patients became very comfortable with that, and after the COVID they don't want to come to the hospital. They want to sit at home and see me from home because we can do everything at home. So I think telemedicine has taken a big step in chronic care model. In fact, in the other parts of the world, the branches of medicine which has taken a big leap in telemedicine are psychiatry, diabetes care, sexual medicine, because there's a lot of confidentiality which you can. In fact, in our app, it's called Home, we can connect my psychiatrist as well as my counselor, etc., to the patient, absolutely confidential. So their visits to the psychiatrist the frequency can be increased because it's easy. They don't have to step out of the house at all. So diabetes care is one of the good examples of very successful telemedicine for chronic care model. Thank you.
Absolutely, sir. That's fantastic to hear. Madam, we have also seen that the microbiology has transformed, wherein during my college days, at the end of a diagnostic modality was PCR, whereas nowadays I think PCR is among the fastest to write. So how do you see nucleic acid based tests, how the NGS is coming up? How should the contemporary lab investigations correlate with the newer advances? Do you see tests like RFLP, PCR, NGS taking over contemporary culture in most diseases?
At the outset, I must thank Dr. Radhakrishnan and Vidya for this wonderful session. And Marvelous Medicine actually has reached out to hundreds of people across, and I think that's a very, very good initiative that you started, and I hope it continues. Coming to your question, it's a very, very pertinent question. Before I go to answer your question, the concept of clinical microbiology is now taken over. The conventional microbiologist, where the microbiologist would just sit in the labs and come whatever specimen they culture and send out the report, the clinician would either look at it or not look at it. So that was the state. But now microbiology, I think, has made an impact mainly through the increasing antimicrobial resistance that you find now, which is almost like a pandemic. And in addition to that, the infectious diseases, the spectrum that has grown, as we saw in COVID, during COVID, that's where the microbiologists did come into their fore. Now, so therefore, to answer your question on whether the molecular techniques will take over the traditional culture, a time may come when it will, but not now, mainly because the bacteria are mutating almost every other day. And to get the best out of what we send out for culture, we need to have what is known as the diagnostic stewardship. That is again very crucial, because as you know, garbage in, garbage out. So if you don't get the proper sample from the patient with the patient's details, the microbiologist sitting in the lab will not know. They just culture it and they send you the report. It could be a contaminated, it could be a normal commensal flora, and you send it out for NGS, you send it out for all the various biofire assays and all that, and what do you get? Nothing. So to get the best out of your molecular diagnostics, you need to be very, very conscious of monitoring your specimen, correlating with the clinical spectrum, and sending out the appropriate sample. Then next we come to, having got the report, how do we interpret it? So that interpretation is again not in the hands of the clinicians, because if I say, okay, NGS, it has got this much molecular weight and these are the genes that we find, but then for you it is Greek and Latin. So that is where the correlation or the collaboration between a clinical microbiologist and an ID specialist comes into the fore. There should be meets over every patient to infer the diagnosis and to interpret the results. And yes, definitely the molecular diagnostics do come, a time will come when it may take over, or it will take over, as it is being done now with all the various rapid diagnostic tests and their outcomes. So therefore, in order to interpret the result and make it really applicable to the patients, whether it gives you the proper result, you need to have a meeting or the correlation between. And so at this stage, I might just add that like the Western countries, we are just waiting to see when a microbiologist will form a team with the infectious disease team to go on rounds and look at the patients and give their input. So yes, there will be a time, hopefully not very far off, when you will have this.
Lalit, if I can just jut in here, you know, a lot of advancements happen in diagnostics, but we clinicians do not know what is available, what is not available. Our knowledge is as old as, you know, what we have learned. I mean, how can that thing be bridged, that gap be bridged, that we should have aware as to what is happening in your field?
Yeah, so that is exactly what where I left off when I said, if you get the team, into your clinical rounds, when you're going on clinical rounds, the microbiologists coming in, especially in your ID wards, you know, or in your ICUs, if you have a clinical microbiologist in your team during your rounds, they will be able to help you and say, okay, this is what we feel, and these are the molecular tests that you can order for.
Do you, do you interact with your microbiologist? Do you get information? Do you have time for that?
We do. I mean, we do more with the infectious disease specialist than with the microbiologist, I have to say. But we do interact with microbiologists as well. But the direct communication is always with the infectious disease specialist.
Yeah, so this is where we lack. You know, the microbiologists are always kind of kept to the background. They are pushed into the lab. And as a microbiologist myself, who I call myself a clinical microbiologist, by the way, and I keep insisting that we must step out of our labs, make the first step, you know, make the first contact with the clinician. And I think in many places that has happened. And if you see that those places where the patient management in terms of controlling infectious disease, treating infections is much better than those hospitals where they do not have a kind of a correlation or a communication with the microbiologist. So it is, you know, a two-way traffic. The clinicians must reach out to the microbiologist, and the microbiologist must step out of their labs to get into the clinical arena and give their inputs.
Thank you, madam. That was a fantastic view. In my own little experience, my microbiology teacher, we have our microbiology in the preclinical years. When I was a house surgeon, I had sent a sample swab for culture. Then I got a call from the lab, you are wanted. And I went there, my HOD was there. She said, this is a swab. How do I know where you have taken from? Do I culture it for a year bacteria or for a perennial bacteria? That made a lot of sense to me that day. I realized that I was out of college and I was now a professional. So till now I write that. It makes a lot of meaning, because with the NGS and other rapid diagnostic techniques evolving, ICU concepts of hit high and then de-escalate once the life is saved, and then probably you cross-check the NGS with the cultures which come the next day or the day after. I think that's a very fantastic way to look forward. Thank you, madam. Sai sir. Hi sir. So we've always enjoyed speed, and today, with being at the head of trauma care and emergency medicine, how do you think we should be using AI? AI, I know, bridges with telemedicine to some extent, but we always know that becoming slightly older in age, covering the nights, the wee hours, where active human presence sometimes becomes a little difficult, especially in remote areas. How do you think AI is going to transform ER?
First of all, congrats to Patta sir and madam for conducting this so big and made this group very big, and for the consistency continuously. You're really hats off, madam and sir, and to all the legends who are here. See, I represent Society for Emergency Medicine, which is the India, which is the biggest society for emergency physicians all over India. See, all people here would have heard the word casualty. So emergency, like Professor Rela, liver transplantation, almost emergency medicine is a very, very new specialty. So almost all hospitals are now embracing emergency medicine because following the guidelines of UK and US. So thinking about the door to balloon and the door to needle times amongst cardiologists here. So emergency medicine is the gateway or the doorway where the patient first steps in 24/7. So AI is definitely the future. So now we have the concept of 5G ambulances. So how the technology is going to be, where I attended a recent AI conference. So when the patient who is in regular follow-up with you, for example, he has come to a master health checkup, his lipid and cholesterol levels were high. So the AI is going to predict this patient might get a heart attack in the next 6 months. Or the patient who is calling to you in the middle of the night to your emergency and needs an ambulance, the paramedic goes and picks up the patient. The treatment actually starts from the door, ER door, but now after AI, it starts from the ambulance door. So treatment starts in the ambulance where we have a direct 5G interface. The emergency physician starts the treatment. So we can even start thrombolysis in the ambulance in case of stroke, in case of heart attacks. So that is going to be the way future. And AI is also going to integrate, which is going to make things very fast for emergency physicians. So the patient directly enters from the ambulance to the imaging, from the ambulance to the OR, and the route will be bypassed. So that is going to integrate a lot of things and make things easy for, and more lives can be saved. So even there are going to be drones which are going to teach CPR, or the drones which can carry defibrillators. Already in the US it has come. The drones are just providing the defibrillators on the spot where there is a cardiac arrest. And you also know about the bike ambulances, which is also already prevalent. And a lot of other technologies are going to make emergency easily accessible, because time is brain and time is muscle and time is nerve. Everything is there. So in ER, time is most precious for all of us. So in that way, I think it will modify the role for emergency physicians.
Definitely a fantastic imagination. Somebody needs to put a fingerprint on a scanner and then the data comes online. There's an automatic AI suggestion that if this guy says some chest discomfort, it could be an MI. So look carefully there. And then by the time the patient lands in the ER, like the doors are already ready, the beds are ready, and we know where to put him. It's fantastic, sir. And we also know that the treatment has been initiated at his doorstep. It's a fantastic way to look forward, quite exciting. But if that's going to be the latest, sir, Professor Sethuraman, sir, we have seen that evolution of medicine, sir, from Boyd pathology, where licks the joint, bites the heart. I still carry that as a memory from college. Nobody talks that to me now. And how do you think the contemporary practice of clinical medicine should be, where our clinical skills are getting honed by diagnostics when we already made the diagnosis and use the latest technology to confirm the diagnosis, versus using technology as the diagnostic tool? Because with AI, everything coming forward, we already saw Dr. Sai looking at AI suggesting an MI. So where will clinical medicine continue to flourish going forward, sir?
I can summarize the dilemma in one quote. No, I think I put up the cartoon in ResearchGate. Some people use diagnostic aid. I think Reba will remember. We used to tell it in our orientation to interns. Use diagnostic aids are illuminating thing. So you do a clinical diagnosis and it gives illumination that you are on the right path or wrong path. Some use it as alcoholic uses a lamppost for support. You don't know what it is, so you do a battery of tests hoping that somewhere you'll get a support. And some abuse it like dogs do the lamppost. As a ritual, wherever a lamppost is there, dog has to do it. So whatever test is available, go on ordering that. So that summarizes the clinician's approach to this. Some are using critical thinking ability and doing essential rational order of investigation. Some do it because of uncertainty, which is part and parcel of clinical medicine. Third, of course, is rituals for various reasons. So that is the dilemma. It was there those days, it is there now also. Now options are many because the technology has improved so much. You have battery of tests. So this is where the 21st century skills become important. In the medical school itself, when we teach critical thinking, creative problem solving, communication skills, and collaborative team-based care. These 4 C's are the important things in all special walks of life in the 21st century, including healthcare. But medicine is not, it's all NEET oriented, NEET UG, NEET PG, NEET super specialty. They're totally cognitive based, and on one hand we say competency based medical education, but competency is never tested. MS gold medalist has to only know the theory. If a person who rattles the book by heart, he gets gold medal. A fellow might faint in the operating room. So that is a reality. So there are fundamental problems are there. So when we raise this to NMC or something, all they do is just ignore us. No, don't call that fellow. He comes and asks difficult questions and all that. So this is the reality. And so efficiency and proficiency are 2 things that we have to teach. Proficiency is knowing 100 tests that can be done in a particular disease. But efficiency is doing the minimum necessary to reach that threshold of diagnosis by which you know that it is there. There is no need to do all the 100 tests to prove that it's coronary artery disease. That way I think AI-based algorithms might come in handy to reduce the medical costs. Because even 20 years back there was a study from Harvard group, I think, saying that there is a 70-year-old man or a 75-year-old female lady patient with classical angina. It's a triple valve disease. Straight away wheel them for angiogram followed by intervention. If it is stentable, do a stenting, otherwise elective surgery following angio. This was told 20 years back. How many hospitals are practicing now, you tell me? Because that is just ignored because it's not good for market. So efficiency, even though it is discovered by some people, it is not done. There are courage trial 1, courage trial 2. I hardly find it being discussed in any cardiology forum. That first one was, I think, 15, 20 years old. Second one was 10 years old. They said for stable angina, medical management is as good as surgical management, and only improvement is quality of life. It is there valid even today. But when I used to say that, no, you are a boomer, you are outdated. So the boomer comes as a very easy thing to tell anyone who tells with age and experience. I've managed stable angina for 20, 25 years. That pressman who's 100 years, nearly 100 now, our Jipper senior pressman, retired press manager, he is in Delhi now. He had a stable angina for 35 years. He got a surgery done, but managed medically because He said until his daughter gets married, he doesn't want surgery. Whenever he comes to Chennai, they'll say, no, get admitted tomorrow, we have to operate. Then I said, don't worry, you will be all right, only quality of life is at stake. So you get operated before retirement. So he got it done now, 30 years post-surgery, is still doing well. So what I mean is, it is not easy to solve the thing. Art of medicine has to come. And the other approaches in many hospitals, the patient is straight away sent to all the laboratory rounds. Before, doctor is like God. The darshan, no, you like meeting Balaji in Tirupati or somewhere. You do all the rounds, see all the peripheries, and then finally you go and see the big man, and they just send off. There is my relative in Pune with a cardiac problem. I think it's a right heart problem. Unfortunately, person echo is done by a technician. He has seen only the left heart and reported normal. The doctor writes cardiac CHF and then given CHF treatment. But in his notes, he says CVSRS NAD. How can CVSRS be NAD? And he has got a pleural effusion which was tapped twice. And he says CHF and he says CVS NAD. Nothing attempted and done. That's what it means. So these are difficulties. So lot of thing is to do with the training. There are some very top school medical colleges like All India Institute, the whole series, even private, Manipal, and many colleges in Tamil Nadu also of high quality. But there are also others who just take money and have a panel of examiners who are very flexible. So these things happen. As Vice Chancellor, I know what all goes on. So this is the problem. So we are our own, in some way we do that. Yeah, I covered that earlier. It's also in my book called Trick or Treat. I don't know how many of you read it. It's one of the JIPMER students have put it on research, ResearchGate, or a Google book you can download. It is like Krishna Devaraya and Tenal Raman, no? They said you have to pour a milk for this thing, that big Abhishekam for the temple in his empire. So they used to put milk and see people are so devoted and full of bhakti, and they are giving 100, 200, 1,000 liters of milk for all this ritual. Then he said it's because they are fearful of you, not because of bhakti. No, he didn't believe. Then he said, okay, you let me handle the next notice, and said, king is not available. However, the puja will go on. Tomorrow, the thing will be done. In the night, you can come and put milk. And next day morning, when Krishna Deva came and saw, it was all water. Not a single fellow had put milk, because there is no monitoring, no. So he said, then he agreed, it's not bhakti, it is only fear. So unless there is some enforcement, either from medical council or our own professional associations of this thing, keeping up the quality, it will all be watered down. So sorry to say that, but I think sometimes we have to call spade a spade.
Humor is the best way to learn and live. And we have seen humor evolve through decades, from the periods of MSK, Nagesh, Manorama, all the way to current. But this is golden age humor. I would have never thought of a dog on a lamppost in a meeting like this. Certain problems are really age related. Such a joke, I am sure a house surgeon will not be able to imagine, or even if he has thought of, would not have the guts to say. But again, the house surgeons also have another problem, sir. Being a senior professor, you should easily know. The patients always find out a new symptom when the chief comes, which they never manage to remember and recollect in front of the junior, the PG, the assistant professor. It's always a professor-related symptom, and then that clinches the diagnosis. Somehow this problem has also remained, I think, unchanged over the period. So certain things, I think the younger generation can be pardoned, sir. They reserve certain things for you only. CVSRS NAD, my God. Nobody would have thought a senior professor is going to look through that case sheet. But the Krishna Devaraya example was really fantastic, sir. because sometimes I feel that is how publications are happening today. A lot of publications are being poured in like the milk out of fear, out of compulsion, driven by various forces. Sometimes helped by AI and verified whether authentic by AI also, I hope. So, Professor Sane sir, my question is, are the current papers really being valid? How does suddenly so many papers get published? And what is the veracity of all these publications? How do we know which one is actually true? Everybody is going through a statistician and p-value is less than 0.00001. And what do we do with the current publications, sir? How do we take quality medical care forward, and how do we choose the right literature to learn from?
Things haven't changed from what they were 20 years ago or 30 years ago. It's just that the volume of information has changed and the number of journals available where you can publish that volume of information that has changed. So you had bad papers being published 30 years ago, you have bad papers being published today as well. You had good journals and you had bad journals, you had good reviewers and you had bad reviewers. You had good editors and you had bad editors, you had good publishers and you had bad publishers. It's just that the proportion has changed. So somewhere the good has become a little smaller and the bad has become a bit larger. The need to publish stems from a regulation, and Professor Sethuraman very rightly said that, you know, unless there's some kind of an enforcement, things won't happen. So in their wisdom, the medical council decided that medical teachers, to my mind it was perfectly fine, should produce 2 good research papers prior to getting promoted to the next level. And I thought that was pretty reasonable. We as medical teachers thought that if we could get our students to pass without knowing much, why couldn't we publish without doing much? And we looked for better avenues, easier avenues. So the opportunity presented itself with some very bright minds, in fact, thinking of creating a different kind of model for publishing. So previously the model that existed was publisher, print journal, reader pays to read. A set of bright minds, Nobel laureates, got together and said, I do research, it's my mind. I get money from funding agencies which are supported largely by taxpayers' money. My research then goes to a publisher who makes a profit on my research because somebody else wants to read my research. So this doesn't sound good to me. And therefore this group of Nobel laureates sat together and said, we'll create something called the Public Library of Science, PLOS. And they thought they didn't need money to do this. So that's where the bright mind faltered. A few months into this program, so I'm talking now about the creation of the open access model for publishing, where the reader no longer needed to pay. It was the person who wanted to publish who could pay, and so this model existed in various forms quite early on. So people like Louis Pasteur, Joseph Lister, when they initially came up with their thought processes, their experiments, and they wanted to get this out into the public domain, journals like, established journals at that time, like the Philosophical Transactions, amongst the first journals, they said this is not conventional thinking, so they didn't publish it. So what did they do? They brought out a booklet and circulated it amongst them, their friends and well-wishers, And the word got out that this is information that could be useful to other people. So the same thing, it was open access at that time. You could print yourself and publish and circulate. We moved forward and we said we create our own blogs and write in our own blogs, and we can write our own research in our own blogs. Now we had a systemized way of doing it. I don't need a blog. I have somebody who's a publisher who runs an open access publication. I need to publish because there is a requirement for me to publish. And therefore I go to this person who has all the wherewithal, doesn't do anything with it. And I say, please publish me. And he says, I'll publish you tomorrow. Because if I go to the New England Journal of Medicine or the Lancet or the National Medical Journal of India, they'll publish me a year and a half later. My interview is in 2 weeks' time. So we created it in some manner of speaking ourselves with a good purpose, but landed up with a tiger which we can't control now. Predatory publishing in predatory journals. And I chair a membership committee of an international association of editors. And when editors apply to be members of this association, it sometimes becomes very difficult to figure out whether this particular journal is a genuine journal or a predatory journal. So that's where we are. I'm sorry, I'm not sure that I've answered your question and posed more issues to it. But I think what has happened has been there for a very long period of time. It's just that the proportions have changed. The good has become less and the bad has become more. And we just need to use our own intelligence to say that, look, this doesn't seem right to me, and put it aside. Just because something gets published in a well-reputed journal, say the Annals of Surgery, for example, doing a journal club with the National Board of Examination students of surgical gastroenterology yesterday, and discussed a paper, and we said, does this tell us anything? Nothing. So why did the Annals of Surgery, which is supposed to be the best possible journal in the world, publish it? They must have thought something about it. They must have found a reason to publish it. So my perception could be different from somebody else's perception, and we therefore need to read everything that comes across critically ourselves and assess whether this is useful information or not. There's no shortcut to that method. Thank you.
Fantastic insights, being very honest and giving us a clear picture of what's in front of us. Whatever we do, we think about the contemporary moment guiding our future. So with a lot of conviction and good deeds, we are here today in a good world. We also see that this is the opportunity to preserve goodness in everything that we do. And as healthcare professionals, I think after this discussion, we have an elite future going forward, and it's our responsibility to keep the goodness and good intention towards human health intact. With that, I would like to hand over the mic back to Vidya Madam for the next session. Thank you, everybody on the panel, for joining me.
Thank you for a wonderful session. I request all of you to just be with us. Two of our speakers who are on Marvelous Medicine are not with us anymore, so we'd like to honor them with a minute of silence. Dr. Guganandam, a public health specialist, and Dr. Debashish Danda, a very renowned, world-renowned rheumatologist. We had the honor of having them on Marvelous Medicine, but they are not with us anymore. We'd like to take a couple of minutes of yours, and then we'll be serving tea in the atrium outside. And also, we request all of you to stay there for a photo session.
more discussions and topics on social, communication, and financial skills which are not discussed in any other platform. My salute to you, Dr. Vidya and Dr. Patta. Carry on the flag high. All the best.
Hearty congratulations, Dr. Vidya, for having completed 200 episodes of Marvelous Medicine. You are doing a fabulous job. I've enjoyed all the sessions I have attended. Considering that you have such stalwarts in their respective fields, I was just wondering if you could incorporate talks from them where they can share, vignettes on how they have faced challenges, how they have managed to overcome, and lessons learned from near miss incidents or mishaps. I think that will be a treasure trove for years to come.
Hello, I am Dr. Jimmy Matthew. I have been part of learning general surgery for a long time now. I congratulate Patta on starting this group. It's a fantastic group and I write on it in it often. I think it's a very nice thing and a marvelous medicine curated by Vidya with great dedication. I watch it whenever possible and I have contributed my bit occasionally. I would have loved to be there in Chennai with all of you. I was very unhappy because as I had to miss it due to some unforeseen circumstances. I wish it all the best. I wish Marvelous Medicine all the best. Congratulations Vidya and congratulations Patta sir. Thank you all. Thanks for the participants have been the best of the lot. I have been very impressed with the participation in this group by young surgeons. I think problems of young surgeons and the politics and the ethics of surgery and how we should go about it in the future and what are the changes that are coming. These are the things on which we need further discussions in the future. That is my thoughts on this. Thank you.
Hi, I'm Dr. Kanchan, practicing neuroanesthesiologist from Bangalore. I've done my anesthesia from JIPMER Pondicherry and I'm very, very excited to be a part of Marvelous Medicine that is now completing 200 episodes. On this occasion, I would like to request the senior faculty of Marvelous Medicine to consider introducing observerships or short fellowships as a part of the activities of this platform. I think that will greatly benefit young doctors and help them get exposure to different healthcare systems in different subspecialties all across India and even across the world. So thank you very much for your efforts.
Hi, Dr. Vidya and your team. Please accept my heartiest congratulations for the successful completion of the 200th episode of Marvelous Medicine. Fabulous program that's both educational and practical. I applaud you for creating and sustaining a program that's become a vital resource for young and mature physicians alike, not just in India but worldwide. Your dedication, your tireless commitment, your ability to navigate challenges and to constantly innovate is truly admirable. Thank you and wish you many, many more years of success. As far as future programs are concerned, I really love all your programs, but more so the programs where we learn from legends. So let's have more of those. We have been blessed to have wonderful teachers in JIPMER, and I think it'll be great to hear from them about their experiences. Thank you.
My name is Krishna Kumar, and I am a pediatric cardiologist at the Amrita Institute of Medical Sciences. I have to start by saying that I am truly privileged to have been associated with Marvelous Medicine and watching the episodes. It's hard to imagine that 200 episodes have happened.
Chick, chick, chick. Chick, tick. check. Check, check. Check this. Check, check. Check this. Check, 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 check. Check, 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 now, check.
Uh, our teacher who's come all the way from Pondicherry, Dr. Sethuraman, are again.
To medical
Learned something.
I'm glad that I've participated in some of them. And the question you're asking is actually quite a long question. Let me come to let me come.
I request all of you who haven't signed our Marvelous Medicine 200 wall to put in your signatures as you leave. The board is right on the right when you take the front exit. Of course, we request all of you to stay back for the rest of the program. We have planned many more interactive sessions, and as of now, we are reasonably on time. We move on to our next panel, which is on modern surgery. Modern surgery cannot start without diagnostics. So we have Dr. Sri Priya, a radiologist who specializes in liver radiology. May I ask Sri Priya to come on the dais? Next, I request Dr. Rupesh Kumar, who is a surgeon in this hospital, who has been part of our Marvelous Medicine journey. I'd like to request Dr. Suresh Babu, a senior neurosurgeon, who has been part of our Marvelous Medicine journey. Next, I'd like to invite Dr. Raghavendran, senior anesthesiologist. Sir. Modern surgery is not complete without the women surgeons who are, breaking down all bastions. So I'd like to invite Jayapriya. You're there? Please. All the advances in surgery wouldn't be possible if there wasn't, a good intensive care team which looks after the patients after their complex surgery. So I'd like to invite Tejaswini Anil onto the stage, please. And to moderate the session, we will have Ilango Setu, our resident Marvelous Medicine surgeon.
In the last 2 years, significant advances in modern surgery and anesthesia have improved patient safety, outcomes, and procedural efficiency. These developments focus on automation, monitoring, robotics, and minimally invasive techniques. Technological improvements in robotic-assisted surgery allow greater precision in complex operations, such as cardiothoracic or gastrointestinal procedures, with reduced recovery times. Enhanced imaging systems, like 3D and augmented reality guidance, now assist surgeons in complex anatomical navigation, improving outcomes. Machine learning algorithms are integrated into surgical platforms, offering predictive analytics to reduce complications. For example, AI can analyze patient data to forecast postoperative risks and recommend preventive measures. Custom implants and tissue scaffolds created via 3D printing have found increasing use, allowing personalized surgeries. This is especially beneficial in orthopedic and reconstructive procedures. Closed-loop systems monitor patients' vital signs in real time and automatically adjust anesthesia dosage, reducing human error and ensuring optimal sedation levels throughout surgeries. Advances in genomics allow anesthesiologists to tailor medication based on genetic profiles. In summary, the recent innovations in surgery and anesthesia enhance safety and precision, fostering better patient experiences. The adoption of robotics, AI, and personalized medicine represents a significant leap forward in healthcare.
Thank you. Thank you, Patta sir and Vidya ma'am, for this opportunity to interact with the giants in the field. So, modern surgery, I really don't know what has changed over the last decade, but what I admired as an intern in 1996 and the surgery that I practice now are completely different. So I think the like they usually say, much water has flown under the bridge. So we took out, I mean, there was lots of discussion in the Marvelous Medicine over these three, but we picked up a few topics which will be of interest to us and then give us a perspective of what we have done. So the first one is, I do see a lot of hybrid operating theaters. I think radiology, surgery is working together, and I think that change has happened in vascular surgery and in neurosurgery. So what is your take, Suresh Babu sir first, and then Rupesh to follow?
I have not worked in a hybrid theater where there is a combination of surgery and this. See, one of my close friends, Dr. Sendilnathan, he had hybrid theater in private sector. I know Dr. Murali also was coming there, and we did a few cases. I took patients there and we did cases. Here now you do an angiogram for an aneurysm, and then you decide on the table whether you need to do a clipping or coiling. Then you can decide on the table. And during surgery, suppose you do a clipping and then you have a doubt whether we did not have ICG those days, and if you want to do intraoperative confirmation that clipping has been done well, then you immediately take the patient to the stitch there and then do it and come back if there's a need to reapply the clip. So, but as of now, I don't think we are using of